Good morning, everybody. It's an indeed pleasure for me to invite my overseas supervisor, Professor David Denning. He is the Professor of Infectious Disease and Global Health, University of Manchester, UK. And also he is the founding president, Chief Executive of Global Action for Fungal Infections, that is GAFI in Geneva. So I would like to welcome Professor David Denning for his speech.
Thank you very much for the opportunity to talk to you again. I'm going to try and give you some different pieces of information from the ones that have gone before. So the spectrum, there's a lot of fungal lung disease, and in half an hour it's impossible to cover everything. But what I want to do is I want to just focus a little bit on the burden and the estimates of different numbers of cases across the world. I showed you this, I think, on the first evening, and one of the challenges here is whether these estimates are right or not right, and part of the problem with that is diagnosis and making a diagnosis, as you know. So if you look at the number of deaths globally, there are about 55 million people who die every year, according to the WHO, across the world, and ischemic heart disease and stroke account for a very large number of those. COPD is pretty big, at 3.2 million. And of course, you can also die of pneumonia, and you can die of pneumonia with COPD or without COPD. So there is some overlap here. There's also an overlap with TB because patients with COPD can develop TB, etc. And I'm going to make the case that a lot of the deaths of COPD are actually related to aspergillosis. Whether this is right or not, I don't know, because we need to prove it. So another way of showing that data is graphically like this. So on the left, you have invasive aspergillosis. Then you have chronic pulmonary aspergillosis, which is numerically a very big topic, probably. Again, diagnosis is incomplete. Invasive candidiasis and candidemia. So as we said yesterday, blood cultures are only 40% sensitive, so 60% of cases are either not diagnosed or not culture positive. And then you have pneumocystis pneumonia, which is also about 500,000 people globally, about 400,000 HIV and 100,000 non-HIV. So that's important consideration. Cryptococcal meningitis. There is cryptococcal pneumonia, but we haven't estimated that. Disseminated histo. There's also pulmonary histo and adrenal histo, which are not included in that. And then you have the other big bar here is mucormycosis, which you do see and is difficult to estimate, but an awful lot of that is based on the estimates from India. So in the paper, the table has a long list and its structure like this. And we think there's probably about 1.5 million people with invasive aspergillosis and COPD every year. Really a large number. And I'll show you that estimate, with a mortality which probably exceeds 95% if it's not diagnosed and treated. And the other really big group of invasive aspergillosis is in intensive care. And I'll take you through that as well. I'm not going to talk very much about invasive aspergillosis in lung cancer, which is another topic area of interest. There's nodules which are aspergillus nodules and not lung cancer nodules, and also the complication of the treatment of patients with lung cancer by aspergillus. So globally, it's difficult to know exactly how many patients there are with COPD every year. The WHO has estimated 200 million, others have estimated 300 million. When we looked at all of the data, which we did about 4 years ago with Jürgen Vespo, who, as you know, is one of his main things is COPD, we thought it was a bit over 500 million people with COPD. And this is gold stage 2 to 4, so not including gold stage 1, which is a little bit more flimsy because people have different sized lungs and heights and different lung function, normal values in different parts of the world. So the rate of admission to hospital with COPD varies from around 3% to about 40% in different studies in different countries. And so it's difficult to take a single value. So using about 10.5%, which is actually a value from clearly well documented from Algeria as a sort of middle ground, we estimate a bit over 57 million people are admitted to hospital with COPD every year. And of course, some people come more than once, and some people come and die as well. Now, there have been 2 really good studies and some others more recently looking at a sequential cohort of admissions to hospital with COPD. In Spain, over multiple years, they looked at this using culture from sputum as the primary diagnostic modality, and the rate was 1.3%. In southern China, in Guangzhou, they did another study. Most of the patients were not on steroids, and again using culture, but also radiology and other factors. They reckon the rate was 3.9%. So that's a 3-fold difference. But it means that if you were admitting patients to hospital, somewhere around 1 in 25 to 1 in 40 patients coming into hospital would have or develop aspergillosis while they're with you. So that's not very easy to see from a clinical perspective. It's just not common enough to be a regular occurrence. And one of the problems here is, how do you make the diagnosis? So culture from respiratory tract, these patients often are more likely to be culture positive. So does that mean it? You can do direct microscopy. If you have both of those positive, that's helpful, but most people don't do direct microscopy for fungi on a COPD sputum. Usually you can't bronchoscope them because they're too breathless, so you can't get a BAL antigen, which would be a helpful test. There's not enough data on glucan testing. We think that antigen is probably not very sensitive in the blood, and the IgG antibody may be helpful, but we know that there will be false positives. So using that alone would not be helpful. But bilateral new infiltrates on the chest X-ray and patients not responding are other clues to the diagnosis. But this is an area where there are no guidelines and no guidance, and we need to work on this because it's a real gap in the literature. And given probably the size of the problem, it really is a big gap. Now, somewhere between 1 and 5% of medical ICU patients develop invasive aspergillosis. Again, it's that low rate, so it's hard to see it from a general perspective. And though the low or high rates vary partly on how much diagnosis is applied to the patients to find it. We know that bronchoscopy is much more sensitive. So bronchoscopy antigen is much more sensitive than culture, and I'll show you that. There's a 25-year autopsy period study from Spain found 2.8% of their deaths had invasive aspergillosis, and I don't think they diagnosed all of them. And in a piece of work that was led from Belfast in the UK, 12.5% of patients with VAB had invasive aspergillosis, which is a pretty high figure. So there's quite a lot of consistency in this data. And the challenge, of course, is that the imaging is not particularly descriptive or clear-cut. You have infiltrates, and only in the bottom left image here would you think, I wonder what that is. That doesn't look like standard pneumonia. And there you've got nodules, which would be a clue. But the other patients have all got invasive aspergillosis. So the radiology is not very helpful, and that's a challenge. And part of the reason that you get a problem with aspergillus is that patients often have had an episode of sepsis or some other insult. They have a typical Th1 response to defeat that, because if you don't suppress a Th1 response, you die of a superantigen disease like toxic shock. So you have to bring that inflammatory response down. And there's a problem with overcompensation of that, so that you get a suppression of your general immune state after an episode of sepsis, which some people have called CARS, compensatory anti-inflammatory response syndrome. And that leaves you open to fungal infection. And actually candidemia usually or very often follows bacteremia. And this is an illustration of that, but it's true for aspergillus as well. And then the other challenge, of course, is these viral pneumonias, which bring people into hospital. So this is probably the highest rate, but there are many other studies looking at influenza and aspergillosis. And most of the patients with influenza and invasive aspergillosis develop it within the first 2 or 3 days of their admission to ICU. So the group in the Netherlands that are particularly active in this area always bronch their patients on admission to ICU. Within the first 24 hours, they have done a bronchoscopy. It's a very quick bronchoscopy, in and out. It's not a long procedure. And the idea is to visualize the airways and to take samples for Aspergillus antigen. And when you do that, you get a much higher rate of positives. But you can see the issue here with influenza, and COVID was similar, although COVID aspergillosis is much, it's later. It tends to occur at 8 days or 10 days after admission to ICU, whereas influenza aspergillosis is early. So you can do an antigen test in the blood, and the overall positivity rate is around 40%. This is work from Delhi. If it's positive, you're much more likely to die of your invasive aspergillosis. And this piece of work from Belgium Leuven, which is the unit I say where they do these bronchs very early, looked at serum galactomannan, BAL galactomannan, and a combination of culture and microscopy. And you can see the much better diagnostic value of BAL galactomannan in this, with a diagnostic odds ratio of 52, which is an awful lot better than culture microscopy, and also from serum galactomannan. So this is a large group of patients that need to be looked at and thought about in terms of invasive aspergillosis. So we think that the mortality from invasive aspergillosis undiagnosed exceeds 95%. It's never going to be exactly 100%, but it's right up there in terms of severity. And that does depend, of course, on making a diagnosis and treatment. So that's the untreated mortality. So one of the other things I did in this big estimate was to try to make an estimate, which of course is just one figure for the whole world, which clearly is wrong, of the ratio between diagnosed and undiagnosed cases. So if you're a leukemia, if you're a hematologist and you're looking after patients with leukemia, there's a very active process of prophylaxis and active CT scanning and doing antigens. And so most of those diagnoses are probably made. Whereas if you take COPD, invasive aspergillosis, you take intensive care, most of those diagnoses are currently not made. So that is where some of these estimates, and if you can treat, you'd get a better outcome, of course. So one of the challenges here is whether that estimate is right. And I think this diagnostic gap is a major, major deal. So another diagnostic gap, and I think it's true in this country and the whole of Southeast Asia, is that chronic cavitary pulmonary aspergillosis has yet to be described from the whole of Asia. There's not a single case from Asia. All of the cases are from USA or Brazil. And why is that? It's a difficult fungus to grow. We haven't got Asperger's antibody, histoplasma antibody. But this is an example of a patient from Argentina with bilateral cavitary disease, which of course is tuberculosis, isn't it? And the patient was treated for tuberculosis twice, but actually had pulmonary histoplasmosis. It's usually in smokers, it's usually in older people. Here are some other illustrations of it. The radiology is not well described either, and certainly it's what descriptions there are mostly US descriptions. The image on the right is a patient with MDR-TB and chronic cavitary histoplasmosis from Indonesia. So we've just published this paper, which is looking at the complications of MDR-TB, who then develop or may have as a co-infection all the way along aspergillosis or histoplasmosis. And you can see it's pretty common. And some of the patients appear to have both histo and aspergillus. So this is a cavitary disease, and if you live in an endemic area for histo, which you do in many parts of this country, this is probably another completely undiagnosed area which needs a lot of work to address. And these patients do progress So the work, even in the US, is pretty limited. We wrote this paper, and the US reviewers all said, we all know that, we don't need to publish this. So they're completely familiar with this disease, and the rest of the world is completely ignorant about the disease. It's a very strange situation. And this is from 1959. So undiagnosed, untreated cases, untreated cases, they were diagnosed. And you can see that you get progression in the majority of these patients. It's slow. It is a chronic problem. And they did a survey many years ago in the 1950s, and 7% of the patients in the TB sanatoria had histoplasmosis. So this is an area which needs some work. So the other areas that we looked at were pneumocystis pneumonia and mucormycosis, and also on this table is fungal asthma. So I spoke about that yesterday a little bit, but it's really, really hard. There aren't very many good data on the deaths related to fungal asthma. So of course, this is a co-problem, right? You've got bad asthma, and then you have a fungus driving it. And one of the studies that needs to be done, if any of you are willing and able, is to take an autopsy series of people who've died of asthma and look for sensitization and fungal markers. And nobody has done that piece of work. And we can't do it very easily in the UK, but it could be done, I think, if you took 25 or 50 deaths from asthma and really actively sought, doing a sort of autopsy bronchoscopy, look carefully at the airways, take some blood, do all the sensitization work, look at IgE and so on. I think you could start to get some idea of whether any of the deaths of asthma are attributable to fungus and fungal sensitization, which I suspect they are. So how do you diagnose these conditions? Well, unfortunately, culture isn't very good, nor is direct microscopy. If they're positive, that's a clue to the diagnosis. It's very helpful, but it's usually negative. The key is antigen and antibody, depending on the circumstances. And particularly BAL antigen. The work in Pakistan suggested you could use tracheal aspiration or endotracheal bronchial aspiration in ICU patients and do antigen, but the cutoff should be higher. But if it's very high, that's very helpful and very suggestive. And then beta-D-glucan has some value in this area. It's not probably very good, and there's missing data on it. And but Asperger's PCR is the other thing that we have found helpful in many patients. It's not actually probably more sensitive than a high volume culture, but it is helpful in some circumstances. It's not as useful in blood unless the patients are neutropenic. So just a couple of comments about pneumocystis pneumonia. You will see this. There's a very large range of underlying diseases associated with pneumocystis pneumonia outside HIV. So anybody on steroids or had some immunosuppression who's hypoxic with an unusual pattern on their CT scan, think about pneumocystis. You can have consolidation, you can have nodules as well, but usually you have ground glass. And pneumocystis PCR on respiratory samples is the key test. You can do basic microscopy, and we did this piece of work in Namibia, looking at GMS staining on these samples, and it was about 70% sensitive, but PCR gives you almost 100% sensitivity. And the other test that's really, really good for pneumocystis is a beta-D-glucan. So this is a really helpful test, and it's very helpful in non-HIV patients. So if you've got a patient that you can't easily bronch, and they're not yet ventilated, then a beta-D-glucan is a clue to the diagnosis. And this should, because it's an important diagnosis, it's very important to get a rapid result in this area. Beta-glucan isn't quite so good for other things. It's particularly good for pneumocystis. And then mucormycosis, which, as you know, is a problem that you have quite a bit of in this country and a lot in India as well. Typically, it's rhinocerebral, but you can have pulmonary cases. And these are challenging to diagnose in many ways. If you can get tissue or microscopy, you see broad, non-septate hyphae like this. but the interpretation can be difficult and requires a lot of skill in the laboratory. If you get a report from the lab saying hyphae seen or fungal hyphae, query aspergillus, that's not a good enough report. You need a description of the hyphae. You need to know what the hyphae are, because it's easy to presume that everything is aspergillus, but it can be mucor. And we did write some standards of how to describe, how histopathologists and mycologists should report these samples, so you get enough description of what is there. As you know, I think the reverse halo sign has been described in mucormycosis, and it's helpful, but not super helpful. It isn't definitive. You can see this in aspergillosis, and sometimes many of the patients don't have it at all, but it is helpful if it's there. And one of the clues to the diagnosis of mucormycosis is the absence of positives. So you haven't got a positive culture, you haven't got a galactomannan, you haven't got a glucan. All of the tests are negative. And that is a clue to the diagnosis. And at the moment, that's the way that the diagnosis is made. But there is hope on the horizon. So there is a new commercial PCR for mucormycosis, which has been launched from a company in Holland, Pathognostica. And this was one of the papers looking at that. It's called Mucor Genius. Not quite sure if that accolade is quite right, but it's a pretty good test with a sensitivity in these pulmonary samples from immunocompromised, immunosuppressed patients of 8.5%. You can see the culture was only positive in 3% of those patients. And this lab compared their own in-house tests, and that was slightly better because one of the key fungi isn't picked up with this assay, although it does pick up some other strains. So like almost every diagnostic in fungal disease, except cryptococcal antigen, it's not a perfect test, but it's a lot better than culture and microscopy. And this very interesting series from France, where an awful lot of the development work for these assays was done, shows that if you screen at-risk patients, particularly transplant leukemia types of patients, and you screen them with a PCR, you can actually reduce mortality because you can get the treatment right earlier. And this is a 20% reduction in mortality with screening. So this is hope on the horizon, and this is one of the tests that needs to come in, I think, to Sri Lanka and many other parts of the world. It's probably a little bit too expensive at the moment and not easy, and it needs a fast turnaround time as well. So there are some challenges to doing it, but we need to do it. And then finally, I want to finish on the issue that I mentioned yesterday in the cases, which is this problem of steroids. Not as a risk factor alone for fungal disease, because we know it's a risk factor for most fungal disease, but the steroids and the impact on outcome. So these 3 studies, which we looked at in the systematic analysis, all show that if you continue steroids in the context of mucormycosis, your outcome is worse. In this example, your chance of dying is 4 times higher, odds ratio of 4.17. That's a lot worse. So anybody with a diagnosis of mucor, if you can possibly stop the steroids or reduce them way down, you should be doing that. We also looked at candidemia, and you can see that in candidemia and invasive candidiasis, the risk of dying if you carry on with steroids is also much higher. Okay, so it's not put out there as a major risk factor for candidiasis, although it is a small risk factor. It's really a big risk factor for dying, and that's a challenge. And the same is true for various forms of aspergillosis. So chronic pulmonary aspergillosis, invasive aspergillosis, and COVID-related invasive aspergillosis. In all cases, carrying on with steroids, it means that you're much more likely to die. So it's very easy to give steroids. And I remember I went to a pulmonary meeting recently, and they didn't know what to do with the patient, so they gave the patient steroids. And one of the panelists said, "Well, you just follow the patient clinically." Well, the problem is that steroids suppress all the clinical factors. You can't follow them clinically once you've given a lot of steroid. So actually, steroids are a really big factor and need to be thought about a lot in terms of the management of these patients. Okay, so some resources available. We run the Aspergillus website for those of you interested, with lots of images, case histories, lots of literature, some of the old historical literature, if you're interested in that. And on that is a drug interaction database where you can look up all the drug interactions, and you can see that there's an awful lot of interactions with itraconazole, voriconazole, which is a challenge in terms of clinical management, but you can look up the ones with terbinafine and other things. And this is available for patients as well. So patients on long-term antifungal therapy, if you give them this access and tell them about it, they can check so that other doctors who are prescribing can, if they don't check or pharmacists don't check, then they can, the patients themselves can check. The LIFE website, fungaleducation.org, has a lot of videos and instructional material and sort of brief summaries of the common and less common fungal infections, and summaries of the drugs and other factors. And this may also be valuable for you as in terms of a resource. And finally, those of you who want a trip to Europe, in March 2026, we'll be running the next aspergillosis and mucormycosis meeting, and you're all most welcome to come and attend. Many thanks.
Thank you, Paul. Thank you, Professor Denning, for those valuable insights that you have provided once more. The forum is open for questioning.
Morning, Professor Denning, and it's an excellent lecture. I'd like to, emphasize the fact of steroids. Actually, I think that one of the clinical trial on steroids in community-acquired pneumonia, critic study published in 2023, there is a major issue actually that everybody is giving now steroids for community-acquired pneumonias. But actually, in the clinical trial itself, they have excluded the fungal infection. But in practice, actually, they are using quite a lot of steroids. And because even the surviving sepsis guidelines, they have recommended steroids in community-acquired pneumonia. And do you have any comments on that, please? Because that is the major problem at the moment we are facing. Everybody coming to the ICU with severe community-acquired pneumonias on steroids.
Yeah, thank you for highlighting that. It's a really big deal. And as I said yesterday, if you have influenza and you give steroids, you double your risk of death. So making a proper diagnosis is important. So this presumably was well-documented bacterial pneumonia, or at least thought to be bacterial pneumonia. That is a big deal. And we will see, and we will get many, many more aspergillosis cases as a result of that practice, I suspect. I think patients with chronic lung disease, COPD, are particularly at risk in this area. So those of you who then consult on those cases or look after them, you need to be really cautious about it. And the key thing, I think, is if you give steroids, is to review it every day. Do I need to carry on the steroids? Can I stop? Can I bring the dose down? You know, when you do a randomized control trial, you have to choose a duration, you have to choose a dose, but that may not be the right dose or duration for everybody. And that's another factor, I think. So thank you for the highlighting of that.
Will you before me? Yeah. Good morning, David. I'm sorry I came late, so apology for that.
Poor you.
Been naughty, sorry about that. So the question really is, we get quite a lot of cases. Some of them may have been treated for lymphoma, etc., and then they end up getting lymphadenopathy, and we end up doing an E-bus on them. And then it comes out saying that, yeah, it's got non-necrotizing granular matter there and not caseating. And then the assumption is made that this is going to be probably sarcoid or a sarcoid-like reaction.
Yes.
And unfortunately, most of the time they say the stains are negative for fungal stains.
Yeah.
Now, are we quite confident to stop there and then say give them steroids or something like that? Or do you think we should go a further step and do some further serological testing?
Well, I'd make a general comment that I don't think the evidence base for steroids in sarcoidosis is very good. In fact, I think it's close to zero. And therefore, I'm not sure that if there's any uncertainty about whether this is a fungus or something else, whether actually steroids, particularly for lymphadenopathy, would be of any value. That's a first comment, and I'm sure you generally agree with that. Making a diagnosis of a latent fungal infection with granulomas like that, which could be histoplasmosis or one of the other rarer fungi, is not possible serologically at the moment. We don't have that test. There is an American company developing a MON2 type or quantiferon type assay for histo, and that might be the way that we go forward with those types of cases. But I would just, again, caution about just giving steroids because I haven't anything else to do, so that's what I do, which is, I think, what would often be the situation there. But I can't give you histology will be negative in many of those cases, and I don't think we can resolve that. It's just not sensitive enough.
And no point doing any serological test then?
No, I don't think it will give you very much value. Coxy serology is really good, but you can usually see Coxy spherules.
Thank you. That's very helpful.
Yeah, one last question.
Yes.
So this is regarding the spectrum of fungal disease with aspergillus that we have, chronic and invasive, and then we can have aspergillus nodule. Is it possible for the other fungus, like what we commonly see is mucor, whether it can cause a spectrum of fungal disease? Sometimes we encounter a nodule when we biopsy it, a solitary pulmonary nodule evaluation.
Yeah.
When we biopsy it, we get mucofilaments on the biopsy specimen. We don't know what to do, how we should manage this. Is it as for an invasive aspergillosis, or it should be, whether it could be resected out and could be managed observantly?
So there is described in diabetic patients chronic pulmonary mucormycosis. So it's rare, but it's definitely described. There was a case series of 3 patients from Pakistan, and there are other cases in the literature. So yes, mucormycosis will produce chronic cavitary disease, usually in diabetics. There's not much data on nodules and mucor. That would be not described, but pneumocystis is described as causing nodules, histo, paracoxy, sporotrichosis, and there's a load of other rarer fungi that can cause nodules. These are rare cases. So I think you just have to address them in that way, as we do other rare cases, is look at what literature there is and try to decide. But there isn't a magic solution to your question, I think.
Question, because that on the literature, the sensitivity of the Aspergillus specific IgG is more than 90% for the diagnosis of chronic. We see a lot of characteristic radiology suggestive of chronic pulmonary aspergillosis, but the serology is negative in many cases.
Yes.
That is the reason that makes us to suspect whether this could be some other fungus causing this.
Yeah, I think you're right to be suspicious, and that's a possibility. And I think we need more work on that area. The labs, Dr. Primmerly's lab, needs to have a second serology platform as well. So there's a second test to do, and because single test is probably not the right way to go. For these difficult cases, we need a second test. But even that will be negative in some patients. So there isn't an easy solution to your problem, I think. And nodules, both Aspergillus bronchitis and Aspergillus nodules have a lower sensitivity than chronic cavitary disease for Aspergillus IgG.
Can you allow one more question? So that we are well aware about that the deleterious effect of the steroids on the chronic and invasive fungal infection. So what about inhaled corticosteroids? Because what we encounter is we get patients with post-TB lung disease, where they also develop post-TB airway disease, which also complicate with chronic pulmonary aspergillosis.
Yes.
And these patients are on antifungal therapy, but in addition to that, they have airway disease with eosinophilic inflammation. And some of these patients, as you correctly mentioned, there is an overlap of ABPA.
Yeah.
So how we should manage this patient?
So there is a suggestion that high dose inhaled steroids lead to a higher rate of Aspergillus colonization and maybe infection. It's not very clear, that database. I think about this as in terms of protected steroid and unprotected steroid. So if you have a patient who's got a fungal infection and you just give steroids, things will not be good. But if you've got good antifungal therapy, then you can add the steroid with some comfort, and it won't, I think, make everything worse. But you need to be comfortable that you're giving good enough antifungal therapy. You know, you have the right dose and that there's some evidence of stability. So that's the difference for me for protected versus unprotected steroid. And I think the same is true for inhaled steroid as well.
Azole resistance.
Yes,
and that's more than 50% of the chronic pulmonary aspergillosis are azole resistant.
Yeah, and that's often because they've been given too lower doses of itraconazole, or they've been given itraconazole with rifampicin and drug interactions. And some of the generic forms of itraconazole are not well absorbed. So it may be that a voriconazole would be a better choice in that context, although even many of the strains that are azole resistant are voriconazole resistant as well. So you need to do multiple cultures, high volume cultures, and ask for a susceptibility test in these patients.
Thank you.
Okay, I think we have a lot of questions to be asked from Professor Denning, but we don't have time. I think we can slowly ask. Even I have some questions, but I hope to ask him slowly. So I would like to wind up this session. Professor Denning, thank you very much for sharing your experience with us. So there is a token of appreciation for you.